And actually, he brought a device just to show everyone.
Okay.
Yeah.
Okay, I'll just, because I need to. I was wondering if you guys can hear me this way or need to use the microphone.
A little louder.
Okay, I'll just use the microphone. Oh, here it is. Hello. Okay, I'm Joe. I'm a registered nurse. I'm a care coordinator from the VA Home Telehealth. And we're using this monitoring device. I'm not sure if anyone familiar about the device we're using for home telehealth. Is anybody familiar? No. Okay. There are 3 ways how the patient can send their readings. Let's just say for diabetes readings. Commonly we use this device that we provide to the patients, of course free of charge. We send it out on a mail by UPS. And the company that we contracted is the Medtronic. Formerly it's a Cardiocom, and it's a Medtronic. So what this monitoring device does is we send it out to the patient, and it's very simple. Of course, you have to connect it to the power source, which I have the power source here, and it's also color coded. So for the diabetes, we provide this peripheral, this attachment device. So orange goes to orange. And that's how easy it's set up. You put also the power source here. And this one has a cellular modem, so it's like a cell phone. So we usually advise our patients that when they use this one to put it right near the window, and then from there, so that, just think about it as a cell phone. If you put it in an enclosure area, you get hard time sending the data. It uses AT&T and Verizon's antenna to send its data. And so the patient check their blood sugar, and after they check their blood sugar from the meter, they can upload. The system will also ask, will do a health check with the patient. It will ask them about if they have any wounds. It will remind them about their diet, if they are compliant in the diet, and they press yes or no. And then at some point, it will tell, it's time for you to send your blood sugar readings. So when they send the blood sugar readings, so they get onto this one, and they just face off. This one has an infrared, it's a glass, and at the top of this Aviva glucometer, there's also a glass here, so they just face it off right, like this, 1 inch apart. And then for, it will upload in seconds, whatever blood sugar readings is in here. And then from here, of course it goes here, from here it goes to us. And that's how simple it is. It also check, like if there's, if you're monitoring the patients for hypertension, it also connects with the blood pressure cuff. It also comes to different sizes that accommodate the patient's size. Again, we connect this one right here is a cuff. And same thing, it will ask the patients about, it will do the health check, and then it will ask them to put their blood pressure cuff in the arm. Then they press yes, and it will check. And then the data obtained from the blood pressure goes from here and it goes to us. Same thing with the weighing scales. It's also, I didn't put the weighing scales, but it connects with a Bluetooth from the weighing scales. Also with the, it also has speedometer, but we rarely use speedometer. The pulse ox also, which we rarely use, and also with the peak flow meter. And it only takes 3 to 5 minutes of the patient to send their data in here. So it saves a lot of time from that. And me on the other end, we can also, this is a two-way. The patient sends their data, and if there's something that I need to talk to the patient, I don't need to call to the patient. I can send from my end some information to the patient, like, okay, it's time for you now to call your doctor about these blood sugar readings, or I can tell the patients like, okay, you need to come to the clinic because we need to see you. The information you sent was a little bit serious, so I need to see you at the clinic, and that's how they respond. The response is yes or no. So this is a two-way system. So this is the first thing that they can send their information to us. The second one is through IVR. It's the interactive voice response system. It calls the patient. We don't provide anything with the patient. It's just like it calls them their cell phone, and when they receive the calls, they answer the same information here, like, are you okay? Do you have anything? Do you have any wounds on your feet that we should know? The response is yes or no through the phone, and then we will ask them about their blood sugar readings, and they can respond verbally or pressing a keypad number, or they could say my blood sugar is 200/200. That's the second thing. And then the third one that they can send their readings is currently we are implementing, or it's already started, but not here at the GLA, the VA, providing them a tablet, an iPad. But it's a little bit costly, and right now it's not because of giving to the GLA, but for some other part of the VA, because it's costly and it needs to be like a patient needs to be trustworthy enough that they won't install it. This is like the charge for it is $1,100, or on top of the monthly service fee of $39.
Could you just speak a little bit more slowly about that piece? I wasn't able to follow those last couple of sentences. Could you just elaborate a little?
Okay, the third one, they can send the data right now. It's at the beginning, it's still in the infancy of like using a tablet. So we provide a tablet to the patient, and we send it out to them, and it's the same procedure. It asks them, and it's like we can see the patient, I can see the patient can see me, and they can. It's either they have the options to see us right there, right moment, or they just go and send in the data readings. But right now here at the VA, GLA, the Greater Los Angeles area, we're not doing it yet because probably of the demographic and the type of patients we have. There's possibility that it might be stolen. It's a tablet, it's an Apple iPad tablet, and it costs like $1,100 if we send it out to the patient, on top of the $39 monthly fee. So with a patient, like if you want to use it, the technology is there, but you have to make sure that the patient is trustworthy enough. Because they might come up with different ideas like, oh, I lost it, or somebody stole it, and then they'll jailbreak the tablet. So that's a lot of money that the VA needs to pay. And then probably next year we're going to start LinkView. LinkView is like they get onto their desktop, and then from their desktop, we provide them camera that they can set up, and then from them to us also, so we can communicate with them face to face over the computer, over the technology. So these are 4 coming up, but right now basically we're using this one and the interactive voice response.
Great, thank you. There was a question?
Yeah, go ahead. So a couple questions on your Medtronic device. When it comes back to you, are you using a separate program from Medtronic to get that information, or how does it look like on your end?
Yes, we have a software that we installed in our computer. Dr. Saul's computer doesn't have that software, so we can't access that. So it's only the care coordinator at the VA that works with home telehealth has that software that was installed specifically in their computer.
Okay. And then for this one, all the patients have to do is plug it into their phone line and then attach the colored cords, or do they have to go through a different setup process?
Yeah, that was the older time. People, when I started 10 years ago, we used like plugging it on the landline. Right now, nobody uses landline. So VA is catching up, so we get rid of that landline. And so the company installed this as a cellular, there's a cellular modem inside this one. So they don't need to have a landline to send their data.
Okay. So they're not connecting to their own cell phones, it's
No.
all enclosed, they just have to turn it on and it's basically set.
But it also has if you look closely here, it's a landline, so there's an option to the patient.
Okay.
For those older patients, that's traditionally called a landline, but it's very seldom now, nobody uses landline.
Thank you.
But one thing is that you could use a cell phone as a monitor though too.
Yeah, if they don't like this, some say, it takes space in their house, but probably it's not. We can use their cell phone. Forget about this. The system, the same principles in here. The system calls their cell phone. It asks the same questions in here, and then that's how they send their data. So that's the interactive voice response.
So it's $39 per month?
The service fee. This one, once we send it out, it's a $430. This one. And then there's a monthly service fee of $39.
I see, and the devices, together with the devices?
There's some charges.
I think we're about $100, about $100 each.
Yeah, something like $100, $40.
That's one-time fee. And then-
One-time fee,
And
yes.
then 39. And what is the compliance rate for patients? Are they doing this on a daily basis?
Yes, we strongly encourage to send their data on a daily basis, and if they only send one or two, it doesn't serve any purpose to us. There's not so much readings, and we just disenroll the patient.
I see. So what is your current compliance rate for VA, for patients who are using this at home?
Compliance rates, at least they use it 5 days or 70-80% at a time.
Patients,
For the patients, yeah. So we're looking at like at least 5 days in a week.
and how many patients you have on this program?
Currently, for the G, I can only speak for.
It's about 1% of our population.
And out of that 1%, you have 80% compliance?
Yes. And there is a floor too, so if patients don't comply, basically they get dropped out of the program.
Yeah, that's what L2 came in. And Dr. Solga discussed about L2, right?
Yeah.
By compliance, does that mean that their hemoglobin A1C drops or not? What do you mean by compliance?
Any compliance?
Sending.
How do you-
Compliance is answering, when there's a question, you answer the question, or you send the data, that's
Or
what
you
we mean by
take your
compliance.
reading? But I think what you're asking is the outcome, like because of this, you have some of those slides coming up?
Yeah,
Oh,
I'll
yeah,
talk
let's-
about outcome.
let him
Okay,
show his
okay.
wonderful
Thank you very much,
slide
Earl.
deck.
Let me move ahead then, thank you very
Yeah,
much.
beautiful, beautiful equipment.
Speak more in the microphone.
Okay, so with this first generation of home telehealth, these are the diseases that were targeted. Basically, these are the diseases that were considered to be higher risk patients more at risk for being hospitalized or going to the emergency room. So they include diseases, diabetes, especially poorly controlled diabetes, congestive heart failure, poorly controlled hypertension, severe COPD, depression, PTSD, weight management, and substance abuse. So as Joe said, there's a daily monitoring only the weekday, Monday through Friday. The home monitor is really set up at the patient's home, and sometimes patients do need help with this, so there is some technical support that the care coordinators provide. The patients enter and view the information on the large screen. There is no video available on these devices though, not with the first generation. And each day, the monitor asks the patient specific questions regarding their disease illness. And this is part of the disease management protocol that Joe has mentioned. Biometric information is recorded, weight, like I said, the peripheral monitoring devices. And after each session, the data is sent securely to the care coordinator. And what the care coordinator does is that, so it goes to actually the third-party vendor website, and the care coordinator has access to that. The care coordinator reviews the data, integrates it into the patient's medical records, and basically provides intervention as needed.
So Doctor, I just don't want you to have to hurry. I think the breakout groups are optional. Take your time, this is really important
Okay.
information.
So the RN care coordinators, they are the ones that decide which devices are best suited for each patient. They will interview the patient, see what disease states are being monitored, and look at the patients with their individual needs. They do help the patients set healthcare goals. They do give regular feedback, and that's the big part of this, is trying to educate the patients on their disease state. They do receive the data, they assess and stratify the patient each day, and they provide ongoing support to the caregivers and along with the patient. So when the care coordinators do see something that is out of line, that's an outlier, they do inform the patient of their condition and ask, may inquire as to what's going on. They may actually provide some patient education to help the patient self-manage their condition. They may arrange for treatment changes, and they may contact the patient's providers if appropriate. They may actually help with the patient make appointments with specialties if needed. And we do have an NP coordinator who's able to make medication changes, especially with diabetes and hypertension. So they're able to do that without other provider input. So for diabetes, the biometric data includes glucose readings, blood pressures, and weights, regular weights. For the disease management protocol, there may be questions such as, do you have new sores on your feet or your legs? Or are you taking your diabetes medication as ordered today? And this feedback really helps the RN care coordinator assess the patient and basically, along with giving the patients tips on how to manage their own healthcare needs. So that was for more of the more serious chronic conditions. We actually have a new telehealth program that's just an offshoot of this program. It's called our L2 program. It's low acuity, low intensity. And this was really to help reach out for more patients who may not necessarily have those severe conditions, but we think that they may benefit from some extra monitoring. So conditions such as tobacco cessation, weight management, hypertension, prediabetes, we can refer these patients to our L2 program, and basically the same care coordinators do basically take care of these patients too. These patients are a little bit more stable. They actually require less monitoring. They interact maybe once or twice a week. Again, we use a similar disease management protocol. And again, the goal here is really to try to educate the patients as much as possible regarding their disease state and try to help them learn self-management skills and really help them establish healthy behaviors. So our most recent telehealth endeavor is our VA Video Connect. And this is where we really have real-time video with the patient. It's really like doing FaceTime or Skype with the patient. And the patient can use their cell phone, their tablet, their home computer, and they're really seeing and speaking to one of their clinicians, one of the team members, their nurse at the clinic. So the nice thing about this is fairly easy to use. It really requires, for most patients, it doesn't require anything rather than just opening up their email link. For some patients who have Apple devices, it does require downloading an app, which can be challenging for some patients. But once that's done, it really doesn't require much else besides looking at their email. Again, patients who may need a physical exam are really not appropriate for this type of visit. So what type of visits would this type of video visit be used in? So one thing is medication dosing follow-ups. If we make medication changes, it might be nice to use a Video Connect visit just to assess whether the patient's tolerating medications, whether they're having any side effects, and just make sure they're taking the medications. Uncomplicated chronic disease follow-up, such as hypertension, diabetes, where we might be able to review labs for the patients. One thing I spent some of my time over at Alton USC doing HIV care. Well, for the most part, many of our patients are fairly healthy, except for they're taking HIV medications and need to be monitored with these medications. Well, instead of having two visits, one visit for lab draw, another visit just to see them, we might be able to reduce this to one visit, just for the lab draw, and then do the other visit through video. Being able to reestablish patients lost to follow-up is another area where this might be helpful. Frail patients with limited mobility. This is one opportunity for us to assess the home situation. We get to see what's happening at home with the patient and see if the patients might be living in a safe or unsafe environment. Immunocompromised patients that might be infectious. Again, this is one area where traveling to the clinic might not be the best thing for the patient. And derm issues, again, with being able to see what's going on, we may be able to assess the patient for their derm issues and wound checks. So appointments to follow up, diagnostic studies, like we talked about, appointments to discuss power of attorney, hospice, limitation of care, advanced directives. This is one area where I think Video Connect will become very, very useful in having the medical social workers speak with the patients, having them going over things such as advanced directives. On-demand, same-day requests to triage a new complaint. Again, when patients come in or have a new problem, this actually, having them on video, we may be able to assess whether it might be appropriate for them to come to the clinic, or maybe they may need labs first, may need an x-ray first. It may actually help us utilize our time more efficiently. Coordination of care. One thing nice about our Video Connect is that we can have multiple people on the same video line. So I could be speaking with a patient, and the caregiver could be in another city, also on the video line, and also the patient's outside doctor, non-VA doctor may be on the line too. So this really does allow us to bring multiple people into the same room, in a virtual room. Post-hospitalization follow-up, at the VA, we do try to contact all of our patients within 48 hours after hospitalization, just to make sure that they have everything that they need and that they're doing well. This is one opportunity for us to actually visualize, how the patient's doing. And wellness checks for patients at higher risk. We certainly have many, many elderly patients at the VA. Sometimes we're not quite sure, how well they're doing at times in between visits. This gives the opportunity to check up on them. So VA Video Connect is not appropriate for first encounters where you really want to develop a rapport with the patient. Doing a history and physical with the patient, that's something that cannot really be done. Highly complex patients with multiple chronic diseases. Again, these patients are probably better served in the clinic where we could actually examine the patient. And patients that live in low bandwidth areas where Video Connect, the experience will be poor. So this does require high-speed internet, so you really need broadband for this to occur. And some patients may not have that at home, which actually may be a good opportunity to utilize things such as the post office or Walmart, where we could have video centers in those locations with broadband. And also we have plenty of patients within the VA, especially who prefer to go to the clinic. It's a lot of times they like to tell their stories. It's more camaraderie just in the clinic. It's more of a social time for many patients.
Can I just ask you on the post office and the Walmart, is that existing now or in the future?
So I heard they signed a contract with Walmart. I think they're still looking into the post office. So the protocol for our video telehealth, number one, verbal consent. We do ask patients to verbally consent to this form of a healthcare visit. Confirmation of a safe and private location, along with somewhere that's quiet. We also review the risks and benefits of telehealth. This is the first time that we do telehealth with a patient. Also having an emergency plan. This is important not just for the medical reasons, but also for the mental health patients, where we discover that this patient has an emergency that needs further help. We do review with the patient their location, their phone number. We do have the patient agree that they will stay on the line until emergency services arrive, along with giving instructions to the providers about Enhanced 911. Enhanced 911 is a service where the service could actually locate a patient based upon their cell phone pings, I guess. And we also review with our patients the proper decorum. It should be like a regular visit. Patient should be fully dressed, and the provider should be fully dressed. There should be no smoking, no drinking. It should be just like a regular visit. So the cartoon here is that you can't list your iPhone as your primary care physician. Well, that may change in the future. And so this is how Video Connect looks from the provider side of the house. Providers will have so providers will have two screens. One screen will be a video with the patient. Another screen will be the electronic medical record that's open, so they can review the patient's record, along with having a video camera. This is a demonstration.
VA is bringing healthcare to veterans wherever they are. VA Video Connect, or VVC, is an online or smartphone app technology that connects veterans with their healthcare team from anywhere. It's easy to set up and use, and completely secure and private. The VA is providing this to make healthcare more convenient to veterans.
Some of the benefits of using VA virtual care are the ease of scheduling, number one. I can get into my appointment without worrying about what time I'm scheduled for, or what time the provider will be able to get me into the office. It's all based on my schedule.
We might not be able to travel to see the doctor. So virtual care is you could take a smartphone and where you could see your doctor and he could see you and he can ask questions. So if he can't be in the locale or I can't be in the locale, we can still communicate and see the doctor that knows us the best.
Veterans everywhere are able to reduce or eliminate travel time to VA healthcare facilities by connecting for their scheduled or on-demand medical visits in a virtual medical room. When it's time for the VBC visit, an email is sent to both the provider and veteran containing a web link. By clicking on the link, the veteran and provider enter the virtual medical room and are able to see and hear each other. VA Video Connect includes a picture-in-picture feature that allows both the veteran and provider to see themselves and anyone else invited to the appointment. Veterans can also flip the camera on mobile devices to easily show wounds or other ailments. When the session is complete, simply hang up. VA Video Connect provides benefits for veterans and providers alike.
I think one of the best benefits, or the many benefits there are to a provider in the VA to use virtual care, is that the patient is ready for you on the other end. Anytime it's good for them to meet, we can make that happen. And that has improved their compliance, it's improved their outcomes. It actually gets them excited about taking care of themselves because they feel like they can connect with their healthcare provider at any time.
What I would say to my fellow veterans who are wondering about using VA virtual care is that it's a no-brainer. It's something so easy for you to take advantage of.
I didn't think I could do it easily, but I was wrong. It's easy once you've done it, and it's very effective. Try it. I think you'll like it.
For more information about how to get started with VA Video Connect, visit the link on screen.
Yeah, so as the patient said, it's easy once you try it the first time. It's easy after that. The first time, actually, there may be some hurdles that need to be overcome. Getting patients to download the right app, getting to them used to being able to look into their camera, knowing which side of their phone to face. Sometimes the patients do need training on that. From the provider standpoint, again, some providers are more tech savvy than others. It does requiring certain things like connecting a camera to their computer or using either a tablet or some other device, laptop that has a camera, and being able to download the necessary software. That does require some technical skills for the providers.
Can you explain how it's like on demand, or is it usually scheduled, or how does that work?
So both. Right now, we're still using it on demand. So a patient may call in, they may have a complaint, and we say, well, why don't we do this on Video Connect? Scheduling is coming. Right now, we're not ready for that, but that is coming. So it'll take the place of regular visits.
Does the VA have a totally electronic healthcare system, EHR?
Yeah. So the VH has their own homegrown electronic medical record system. It was really built.
It's compatible with this, or you transfer the data?
So part of that is the data that's used in Video Connect is, I guess Video Connect is similar to the programs that we have in home telehealth. And so it does require, in home telehealth, it does require some person to try to make sure that data goes into the electronic medical record correctly.
So you have a vendor who does that?
So for home telehealth, there is. For VA Video Connect, right now, we don't use any peripheral monitoring devices right now. That is coming though. And I'm not really quite sure, I don't know what type of form that's gonna take.
I would imagine that this is the kind of system you're gonna build on, like you're
Right,
gonna
right.
have telemedicine consultations,